talk about is your trauma. So trauma, speaking of a trauma, people. So whenever the trauma people comes, like a trauma is one of the most common cause of a death in the early 40s, and it is also the third most common cause of death overall. Okay, so speaking about the trauma, what do you do being a ER physician? What do you do in the trauma unit? What do you do when you are in the ER physician? Whenever there is accident or whenever there is RTA happening and people have been bringing up to you, what do you do first in the ER?
Primary assessment.
The first thing you have to do is, in the case of a mass accident or RTA, what do you have to do?
Triage.
The nurse will be standing on the door, and they will do the triaging. Okay, you will always have a triaging person in the ER. So what do they do in the technically? What do they do in the triaging? They are technically classifying the patients, which one is important and which one is not important, whom they can able to see it later. So in ER, at the entrance, you have the person called as a coding or triaging nurse. And what does the triaging nurse will do? She will triage the patient based on the color code. So what does the color code indicates? The color code is a group 1 is red, which is
Immediate intervention.
critically ill people. You should be taking them immediately as early as possible. And the class 2 is like a yellow people should be treated within
6 to 24 hours.
Yellow people should be treated within
10 minutes.
And the third one is a green category. That's the one you can able to see it later, but you have to see it like within 24 hours or more. Okay, so the group 3 is a minor injury patient where they can code it as the green. And last one is the black one. Black one is the black one, people. You can see the screen and you can say me, no problem. Dead patient. Okay, so in the triaging, the first priority goes to whom?
Red.
The first priority goes to whom? The first priority goes to the red guy, and the last priority goes to the black guy. Okay, in the triaging, the first priority goes to whom and the last priority goes to whom?
First priority red, last priority black.
The least priority will goes to the dead patient or the black patient. Okay, now the nurses has been triaged and you receive a patient with the red coding, people. So when you do the receiving a patient with the red coding, what do? You should perform 3 surveys. What are they? Primary survey, secondary survey, and tertiary survey. Okay, so you should perform a primary, secondary, and tertiary survey. And in that, the primary and the secondary survey should be done within the golden hour. What is the golden hour? What is the golden hour, people? Come on, talk to me. The more you talk, the more you learn. The more you learn, we just discuss more and more topics will be coming on the topics. Yes, what is the golden hour? Come on, people.
First 10 minutes.
It's an hour, golden hour. The first 1 hour, as soon as the patient enters into the ED, the first hour is always the golden hour. Why does it called as a golden hour? Because the patient's life or death totally rely on that golden hour. Because like 60% of the people, if you manage them correctly on the golden hour, then they can survive. Okay, then they can survive. That's why they used to call it as a golden hour. And in that golden hour, you need to perform your primary and a secondary survey. So what are the components of primary survey and what are the components of secondary survey, people? So speaking about the primary survey, what are the components? A, B, C, D, E. Now the ACLS has modified that exsanguination of your blood. Like whenever the patient comes to the RT and blood is oozing out, you have to first stop the bleeding first, and then you have to simultaneously manage the airway. Okay, so now the criteria has been changed as an exsanguination of the blood followed by airway, followed by breathing, followed by circulation disability and exposure. But the standard protocol is you have to go with the A, B, C, D, E. What is the A stands for? Airway. And B stands for?
Breathing.
B stands for breathing. And C stands for?
Circulation.
And D stands for?
Disability.
And E stands for exposure.
Exposure.
And E stands for exposure. So A, B, C, D, E, you have to manage, people. So first we talk about the A, airway. So speaking about the airway, so look at this scenario, people. Look at this scenario. What's this? A patient, someone read the question, please. Someone kindly read the question.
A patient involved in a car accident and presented with multiple injuries, and he is fully conscious and his voice is normal. His airway intact. So
Is his airway intact? A patient involved in a car accident presented with the multiple injuries. He is fully conscious and his voice is normal. Is his airway intact? Is his airway intact, people?
Yes, because his voice is normal.
Okay, yes. Okay, now we modify this scenario. Yeah, again, read the second one.
A patient with
His
multiple
airway-
stab wounds arrives in ED, full conscious and his normal voice. Also expanding hematoma in the neck.
Yes. Yes. So, what is his airway intact? Multiple stab wound, arrives in ED, is fully conscious, and he has a normal voice. He's speaking normally, but he has a expanding hematoma. So, is his airway is intact?
No.
Yes, it could be intact.
Is his airway intact or not, people?
Yes.
Yes. Okay. And who said no? And why there is a no, man? Why his airway is not intact?
There is an hematoma.
It should be bleeding.
He's having a bleeding, but he's having a normal voice. And he's fully conscious, you know. He's having a normal voice and he's fully conscious. His airway is intact at present, but what will happen in the future? He may have that airway blockage in the future. Why? Because there is an expanding hematoma, and there is a possibility that expanding hematoma may compress his airway in the future. Is his airway intact at present? Yes, his airway is intact at present, but will his airway be intact or like being a normal person? No. This expanding hematoma may compress the trachea at any time. Okay, this expanding hematoma may compress his airway, trachea anytime. So what do we do next? So we now found the problem. We found the problem. He's conscious and he's awake and he's having expanding hematoma on the neck. Okay, his airway is intact now, but he may soon have his airway blocked due to this expanding hematoma, which can able to compress his trachea. Now, what do we have to know? We identified the problem. What will be the solution, people? What's the next step? What's the next step? Come on.
Identifying the.
What do you have to say? You have to secure the airway. You have to secure the airway. How do you gonna secure the airway?
Intubation.
Yeah. What type of intubation you do? Nasotracheal or orotracheal or endotracheal?
Endotracheal.
You should not always take your knife, man. You should not always take your knife. When the mouth is open and you have seen the airway, what do you have to do? You have to do the orotracheal intubation here. What do you have to do? Orotracheal intubation here. You should not always carry your knife and put it on the, like a patient's neck. No, that's not the scenario here. What do you have to do? What do you have to do? In the ED.
Yeah.
As an ED physician, you have to intubate this patient, but you have to put an orotracheal intubation. You take your laryngoscope and you put it in this, and you see the larynx, and then you have to see whether you will pass down the vocal cord, and you see the larynx, and then you put a tube in it, and you make sure that the tube passes through the trachea. And once this trachea has been, once the tube has been passed through the trachea, then even though if there is a expanding hematoma comes and compresses the trachea, we still have the pathway to give him the airway he needs. Yes or no? Am I right or
Yes.
wrong? Okay, so in this way we can able to say secure his airway. We are talking only about the airway, so this is what we we try to do that in this patient. Okay, now so he can die at any time. We need to do what? We need to do what? Orotracheal intubation. We need to what? We need to do what? Orotracheal intubation in those people. Okay, let me move on to the next scenario, people. Okay, what's the next? Someone read the question, please. Yeah, go ahead.
A patient with multiple stab wounds arrival in the AD fully conscious, normal voice, and he also has subcutaneous tear, which is emphysema in the tissue in the neck and upper chest. What is the management?
Okay. Yeah. So what's the difference between the previous guy and now? What is the problem here, and what is the change of scenario here? Can someone tell me? Here, the patient is with the multiple stab wound. He arrives in the ED, fully conscious, and he has a normal voice. Yes or no? So his airway is intact? Is his airway intact?
At the moment, yes.
At the moment, yes. But he also has
Emphysema. Oh yeah.
subcutaneous emphysema, which is in his neck and the upper chest. That indicates what? Subcutaneous air or emphysema in the tissues of the neck and upper chest. What does that indicate? It indicates that he has a tracheal injury. Consider that this is your pathway, airway of this patient. And whenever you see this airway, this is your trachea. Consider this is a trachea. And then when you are moving down in the trachea, this patient have a rupture in the trachea, so that whatever the air he is inhaling, it is going there and it is leaking through that pathway. It is affecting his surrounding tissue. That's why you see that there is a subcutaneous emphysema in the neck. Yes or no? Subcutaneous emphysema in the neck. If we left this airway same like this, what will happen? Whatever the air he is taking in, it's gonna accumulate. It will raise the pressure inside your compartments of the neck, and then it can compresses the airway further, and then the patient may, get an airway blockage in the future. Am I right or wrong?
Yeah.
Yes or no? You see where the problem is? You see the subcutaneous air indicates that there is a problem with the rupture airway. The airway is having a problem. The trachea has been ruptured and the air is leaking through the ruptured area, and it is surrounding the tissues. So if you leave it like this, then what will happen to the patient? It may compress the airway by increasing the pressure inside the compartments of the neck, if I am right. So in this scenario, how are we going to manage this patient? How are we going to manage this patient? What are you going to do in this patient? How do you manage his airway? Faster, people. How do you manage his airway?
Tracheostomy.
Don't go for surgery, man. I know it's a surgery and you love surgery, yeah, but don't always take your knife when you have an option. You should, before you shift it to the OT itself, patient dies. Yes or no? What do you do in this scenario?
I think administration of O2.
You need to secure his airway. You need to intubate this same patient. But what is the problem with the intubation? What is the problem with the intubation here? Because you need to secure the airway alone in the ED, because you're standing in the ED, trauma patient came and he has a subcutaneous emphysema, and you need to intubate this patient, because if you don't intubate the patient, the compartments will get compressing the trachea, and then the patient may again goes unconscious and the patient goes arrest. So how do you secure his airway here? You need to intubate, but there is a problem with the intubation. What is the problem, people? What is the problem here? So, okay, let me put it here. Consider this is his airway, right? Yes or no? Consider this is his damaged airway. Consider this is his damaged airway, and you are intubating this patient. You are doing a orotracheal intubation, and you are inserting a tube, and blindly, and the tube may go, and there is a chance that it may rupture here, right? Yes or no? Am I right?
Yes. Injury.
Yes.
Yes.
Yes. So it can further worsen the injury. It can further worsen the injury. So how do you secure the airway in this patient? You have to do the bronchoscopy guided orotracheal intubation. That's the difference here. You have to do the scopy guided orotracheal intubation, so that you have the tube here. So you have the tube which is going in with the camera, and then they can point out where the problem is. So you should not rupture that area. You insert a tube in the area which is where you can able to reach further without damaging that like an injured part. So you have to do in this patient, you have to do what? Scopy guided orotracheal intubation. Scopy guided orotracheal intubation you have to do. Okay, fine. So next scenario, people. Talk. The more we talk, the more we learn. Read the scenario, people. Someone kindly read the scenario.
A patient involved in severe car accident, multiple injuries, and he's unconscious, breathing spontaneously, and the breathing sounds are smooth. What is the next thing we need?
A patient is involved in a severe car accident and has multiple injuries. The patient is involved in a car accident and has a multiple injury. Is this patient conscious? Is the patient conscious, people?
No.
Is the patient conscious? No. He is breathing spontaneously, but his breathing sounds were smooth. Yes. What's the next step? He is unconscious, but he is saturating and breathing is fine. What do you do in this scenario? Move on to next patient. Yeah. Move on to next patient.
No.
Oh,
No. Why not? He's breathing fine. His airways are fine. All the fact is that he is unconscious. That's all.
He is unconscious.
Yes.
he is unconscious, so he comes in the first category where we need to give him immediate attention.
Yeah, but his
Because-
breathing, what you will do in the immediate attention? A, B, C, D, E. A is intact. You move on to breathing. Breathing is fine. And next, C, circulation. You go for the
He's
circulation.
having-
You finish your survey.
He's having a
Yes.
head trauma.
Could be CT can be done.
Yes.
But at present you are in a trauma unit. You have multiple patients. Yeah, write him a CT and move on to next patient. Because he is having a head trauma, write him a CT and move on to next patient. Yeah.
Yeah, that could be done, because we can transfer him for the scan.
Okay, let me tell you, people, this guy is a tickling time bomb. Why he is a tickling time bomb? Because he is unconscious. Though his airway and breathing are normal, he is unconscious. In unconscious patient, what will be the common thing you will have? You will have the absence of gag reflex, and then the tongue may roll back and compress the airway at some point, because he is unconscious. He is unconscious. So his tongue may roll back and it can able to block his airway. When he blocks his airway, you go and you move on to the next patient by writing the CT, and then you, after some time, you see him not breathing. After some time, you see him not breathing, for God's sake. And then what do? Let's resuscitate this patient. You come back to him and you do the resuscitation. He had gone to this respiratory arrest, and then you do the resuscitation. Okay, yes or no? You do the resuscitation. When you do the resuscitation, what do? You initiate with the CPR. Am I right? You do that? You do this? Do you do that? Do you do this, man?
It's been 24 minutes. It's time to call the code.
No. The normal, you check his pulse is not there. You check his airway is not intact, he's not breathing, he's gone to death. So what do? You try to revive this patient, you initiate the CPR, and what's the compression ratio in the CPR? What is the compression ratio in the CPR? Faster.
30:1.
31.
30:2. If there is a skilled person is doing the CPR, what is the compression ratio? Compression ventilation ratio?
30 compression and 2 breaths.
No, if this is for the unskilled. For the skilled, go to 15:2, because if you are in the hospital setup, you can do. And one person can do how many cycles of CPR? Effective CPR can be done till how many cycles? Whatever I'm talking
120.
about is MCQ. Whatever I'm talking about is MCQ. Come on, talk. The more we talk, the more we learn. Yes. Compression ratio is 30:2, 30 compressions and 2 breathe. And if it is a hospital setup, yeah, 15:2. Yeah, next. Okay, how long effective CPR can last by the can be given by the single person? How many cycles? Go
120.
ahead. 4 cycles. Up to 4 cycles he can do it. Okay, up to 4 cycles he can do it. That is a 4:30:2. 120 compressions is right. But up to 4 cycles he can give the CPR maximum of 2 minutes. The effective CPR can be done by the maximum of 2 minutes, and then it should be replaced by whom? Another guy have to replace the CPR position, and he have to do the compressions. Okay, fine. You do the compressions, and if you are seeing like the patient is not reviving, you should immediately do the intubation, and you should this patient are trying to provide the airway to this patient. If you don't secure the airway, what will happen? If you keep on doing the compression, and the code is happening. He's doing the compression for 24 minutes.
It's been 24 minutes. It's time to call the code.
Yes or no?
This is my code. You gave me this code. She's 21 years old. Harder, man. You need to feel the ribs crack.
That's enough.
No, move.
So what is
I'm
it
not
trying
giving
to
up.
do? What is it trying to do?
I said that's enough.
What did he do? What did he do? What did he do? Come on, talk. He revived the patient?
Amber.
Yeah. He revived the patient? Yes? Did he revive the patient?
Yes.
Yes, but how long he has been giving the CPR? But how long he have been giving the CPR? 24 minutes. You didn't hear the guy? He had been giving the CPR for how long? 24 minutes. Is it right? No, because lack of oxygen to the brain for more than 20 minutes could result in what? Could result in what?
In coma.
No, brain death.
Brain death.
Lack of oxygen to the patient for more than 20 minutes. The patient will be brain dead. He may save the patient, but that patient gone to? But the patient gone to? Patient gone to? brain dead, and the only option we can do in this patient is, the only option you can do in this patient is, what can we do with this patient? Read the topic, people. What can we do with this brain dead patient whose heart is
Organ
intact?
transplantation. Yeah.
She'll be only used for transplanting her organ. Apart from that, nothing can be done in this patient. But there is a criteria for the establishment of the brain dead. Okay, there is a criteria for the establishment of the brain dead. Who should examine the patient and declare that the patient is brain dead? Who should examine the patient and declare that the patient is brain dead? Is it a general physician, or like an internal medicine, or maybe a specialist neurologist? Who should examine the patient?
Neurologist.
Anybody can do, but there is a complete neurological examination should be first completed, and his core temperature, his or her core temperature should be above 32 degrees centigrade, and with no evidence of drug intoxication or poisoning, and no medical conditions like acid-base imbalance or endocrine disturbances, then we can able to establish the brain dead. No electrolyte abnormalities or endocrine disturbance or hypotension, no poisoning, body temperature is above 32 degree, and brain functions are totally, totally not there. Okay, then you can able to establish the brain death. Okay, and this patient can be used for organ transplantation.
Organ
So
transplantation.
this patient can be used for organ transplantation. When you do the organ transplantation, we have the graft, and what are the types of graft we are having in the organ transplantation, people? We cover the organ transplantation here itself. So we are having a 6 type of grafts. What are they? Allograft. Talk, people. Everything is important. Everything is important for FMGE. Allograft, and then
Isograft.
isograft.
Autograft.
Yes.
Xenograft.
Then,
Orthopic graft. Heteropic graft.
very good. Okay, very good. So what is this allograft means? What does this allograft means? So it will be shared from the one individual to other. It should be shared from one individual to other individual. And what does the isograft mean? What does the isograft mean? What is the isograft? What does the isograft mean? Between the identical twins. Between the identical twins, we can able to change the organs. Then they used to call that as isograft. And autograft? Autograft means?
Same individual.
Yeah, within the same individual. For example, a patient has abrasion in his hand or a wound in the hand, and he needs a skin to be sutured, placed and sutured. Then we can able to extract the skin from some other part of the body and put it in the where we can able to take a graft from his own body, and we can able to implant in his own body. This type of grafting is so called as autograft. Well, xenograft.
Between
Come on, people.
animal to human.
Any of the 2 species. How many of you know that there is a former chief minister of Tamil Nadu who is a dead person called as Muthuvel Karunanidhi, MK? Yes or no? Do you know him? Do you know? He underwent a xenograft. Do you know why he always wears the glasses? Because one of his eyes are grafted from the goat's eye. Do you know that? Do you know that? Because that's the kind of thing we do for the human being. We transfer the eye from the other species or heart from the other species, and then you put it on that human being. That type of graft is so called as xenograft. It is between the 2 species. Okay, and then you have this orthotopic graft. What is that orthotopic graft indicates? Placed in normal anatomical site. Okay, placed in a normal anatomical site. And heterotrophic is site different from the normal location. For example, like the Chinese guys do that. Yes or no? They planted a nose on the forehead instead of the nose where the nose is supposed to be there. They planted the nose on the forehead. Am I right or wrong? This kind of thing is so called as heterotrophic graft. Some people may have the implantation of thyroid gland in the hand, and some people may have this. These weird fellows can do this thing, like, like they put a nose on the forehead, they put a nose on the hand, everywhere they can do it, right? This type of graft is so-called as heterotopic graft. While you place it in the same normal anatomical site, whatever you've taken off, you put there the same anatomical site, the same thing, then we used to call that as a orthotopic graft. Okay, you the types of graft, people? Clear about the types of graft? Yes?
Yes, sir.
This is kind of like they may ask you in a straight MCQ question. So allo means individual to another, iso means identical twins, auto means within the same individual, xeno means two different species, orthotopic means placed on the normal side, heterotopic means site different from the normal site. Okay, so then you have to do the HLA matching. The common HLA antigens which is required for the organ transplantation are, only this is important, people. Which one? The common HLA antigen, A, B, and D are in terms of HLA class 2. So for class 1, A and B are important, and the class 2, you need to look after this. You need to look after this, DR. Okay, you need to look after this, DR, and HLA mismatching is the most common cause of graft rejection. HLA mismatching is the most common cause of HLA mismatching
Graft
is the
rejection.
most. Yes, very good. So speaking about the graft rejection, what are the types of graft rejection we are having, people? What are the types of graft rejections we are having? Hyperacute,
acute,
acute,
chronic.
and chronic. So speaking about the hyperacute, acute, and chronic, hyperacute is the one which occurs immediately. Okay, which occurs immediately within minutes to hours. So the problem with the blood group or HLA matching, then you may see the hyperacute rejection, which is characterized by, what are the characteristic features you may see it in the hyperacute rejection? What are the characteristics you may see it in the hyperacute rejection? Faster,
Intravascular
people.
thrombosis.
Intravascular thrombosis. Very, 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 very important. Okay, you may see the intravascular thrombosis in the hyperacute rejection because the problem is in the blood group mismatching or the HLA mismatching, or the patient may have the preformed anti-HLA antibodies. So whenever you put a graft, it will be rejected by this auto-antibodies, or it will be destroyed by this auto-antibodies. So most common organ which is vulnerable to the hyperacute graft rejection is again a question that is a kidney, and the most common organs which are relatively resistant to this hyperacute rejection, which are heart and liver transplant. Okay, then you have the hyperacute rejection. Acute rejection is within the first 6 months. Within the first 6 months, it is a T cell dependent. Another important MCQ. So acute is T cell dependence, and in the hyperacute, you may see the intravascular thrombosis, and you may see the chronic one, which is characterized by myointimal proliferation. Okay, so we will discuss the chronic later, but you need to know these 3 words for the acute, hyperacute, and chronic. So hyperacute, it is an intravascular thrombosis. It occurs from minutes to hours, while the acute, it occurs during 6 months. And is it what cell dependent, people? It is what cell dependent? T cell dependent. And then you have this chronic rejection. This chronic rejections will occur after the first 6 months, and it is characterized by myointimal proliferation in the graft arteries, which can lead to ischemia and fibrosis. So myointimal proliferation is chronic, T cell dependent is acute, and you may have this intravascular thrombosis and hyperacute. These 3 words you have to remember in terms of a graft rejection. Clear about that? Clear about that? Shall we move on to the next area? Yes. Can I move on to the next area, people?
Yes, sir.
Okay, very good. Okay, let me go on to the next area. So what are the manifestations of the organs after the chronic graft rejection? So kidney will have a glomerulosclerosis, pancreas will have the acinar loss and IL's destruction, heart will have the accelerated CAD, liver will have the vanishing bile duct syndrome, and lungs will have the obliterative bronchiolitis. These are the common effects we may see in the case of your chronic graft rejection of a particular organ. So for example, kidney will have the glomerulosclerosis, liver will have the vanishing bile duct syndrome. Liver is the only thing which is important for the FMGE. So you have to remember what is a common manifestation which is occurring after the chronic graft rejection. That is your vanishing bile duct syndrome. So what are the six types of transplantation we have? Say me, what are the six types of transplantations we have? Autograft, faster.
Isograft,
Autograft,
allograft,
allograft,
xenograft,
isograft, xenograft, orthotopic, heterotopic. Which one is between the twins? Which one is
isograft,
between the twins? Iso. Which one is between the from one individual to another?
allo,
Allograft. Between the two species.
Xeno,
xeno,
Placed in the normal anatomical site.
ortho,
And placed different from normal location. Placed different from normal location. Go ahead, talk people. Heterotopic graft. Heterotopic graft. Within the same individual it is? Within the same individual. Autograft. Same auto. Okay?
yeah.
Autograft. Okay, so these are the organ manifestation, and the next important area in the transplantation is very, very important. So what are the acceptable donor age and what are the cooling or transfer time for the important transfer time for this organ transplant? Okay, so what are the acceptable donor age and what are the transplant time or storage time of each and every organ? These are the two things which is important here. So for the kidney, up to 2 years, you can able to, from the 2 years, you can able to do it. And then liver, no age limit. Heart, 1 to 65-year-old people can be able to transplant the heart. Lungs, 5 to 65 years. Pancreas, 10 to 60 year. Okay. From the 2 year to no any age, you can do the kidney transplant. And no age limit for liver. And 1 to till 65 years, you can, up to 65 years, you can do the heart transplant surgery. And up 5 to 65 years, you can do the lung transplant. And 10 to 60 years, you can do the pancreatic transplant. Okay, clear about that? Yes, people. So this is the age limit. This is the age limit in terms of your what do we call it? This is the age limit in terms of your organ transplantation. What are the absolute contraindications? So prior moving on to the absolute contraindication, I want to talk about the cold storage time. So speaking about the cold storage time, people. So kidney, how long we can able to store the kidney? How long we can able to do this, store the kidney? Normally less than 24 hours you have to transplant, but maximum in the deep freezer, how long you can do? Maximum in a deep freezer, how long you can do?
48 hours,
48 hours. And in the liver, within a 12 hours you have to transplant. In the deep freezer, how can you can able to maximum maintain?
24 hours,
24 hours. For pancreas, less than 10
less
hours,
than 10,
maximum is 24. And small intestine, heart or lung, it should be less than? It
3
should be
hours,
less than 3 hours and maximum of
8 hours,
8 hours. Okay, less than 3 hours and maximum of 8 hours. How many of you watched the Chennai Lorinal movie where they transplant the heart and they do do by the road? Yes or no? But actually, it was a real incident which has been happened. So they transferred the 300 kilometers of heart within 4 hours. Okay, but unfortunately, they couldn't able to save the patient. It went to the graft rejection. Anyway, fine. So next scenario. So you have to do the organ transplant in the patient people. So scenario 3 was a little bit wider, and we captured all the organ transplantation part itself. Okay, understood the scenario? Clear? Shall we move on to the next one? So organ transplantation. You understood? You want to write? You need some time to write the storage timing and all, or you have already written on your notes? You're just highlighting it. Just you can tell me, I give you the time, no problem. You can write it down. Okay? Yes, shall I move on?
Okay, sir. Yes, sir.
Yes? Yes? Okay. So speaking about this, someone read the question, please. Someone read the question, people. Come on, come on, come on. Someone read the question.
Patient involved in a severe car accident has multiple injuries and is unconscious. Breathing is spontaneously and breathing sounds are smooth.
Okay. What's the next thing you need to do in this patient? Patient has multiple injury. He is unconscious, but his breathing is fine. Breathing sounds are smooth, no problem. As you see, there is a problem here. What is the next thing you have to do? This is similar to previous scenario, yes or no? Am I right? Is this similar to the previous scenario? Is this similar to the previous scenario? Same unconscious patient, breathing spontaneously, breathing sounds are smooth. Yes? So what do you do in this patient? What did we do in this previous scenario? Because in the previous scenario, we didn't do anything. Patient went for death, and we tried to resuscitate, and it ended up in a brain dead, and we did the organ transplantation, and we talked about what are the protocols for the organ transplantation. Am I right? Now, if you know that the same patient is coming to you, and now what do you do in this patient? You didn't do anything in the previous scenario, and all these things, the mess happened, and you cleared up the mess. And now the same patient or the same scenario is coming again to you, and you learn from your past lesson. Yes or no? If you leave this patient unattended, this patient may go for the arrest because of the back rolling of the tongue and blocking of the airway. Yes or no? So what do you do in this patient? What do you do in this patient? Now you know, you learn from the mistake. How do you correct your mistake? What do you do in this patient? Yes. Come on, people. Fast, fast, fast. What do you do in this patient? What's the next thing you have to do? Intubate. Yes or no? You have to do the. You have to do that. You have to secure his airway. You have to intubate this patient. Orotracheal intubation. You have to do. But prior doing the orotracheal intubation, we have a criteria for that orotracheal intubation. What's the criteria? And that's the important question for the FMGE that you have to know, people. Clear-cut FMGE question. So whenever the patient is unconscious, he is breathing spontaneous, his breathing sounds are smooth, his airway is intact now, the next thing you need to do is assess his GCS, Glasgow Coma Scale. Assess his GCS, because the MCQ stands here. The unconscious patient to be intubated whenever his GCS is less than 8. That's the important MCQ question. Do you understand now? Whenever the patient is unconscious, you have to intubate the patient. But prior intubating the patient, what do you do in this patient? What do you do in this patient, people? Prior intubating him. Faster. I just told. Come on, you have to talk. The more you talk, the more you learn. Yes. What do you do? Assess his GCS, because we need to intubate only when the patient's GCS is less than
8.
8. That's the important FMGE question that you have to know in terms of licensing exams. So you understood now that you need to do his GCS. How do you assess his GCS, people? How do you assess his GCS? This is a Glasgow Coma Scale. Pretty important scale, 5-star topic for FMGE. So it has 3 components. What are the 3 components?
EVM, eye, verbal, motor.
Yes, eye, verbal, and motor. So speaking about the eye, whenever the patient opens the eye spontaneously, then you should give him. You should give him how many points?
4 points.
4. And eye is open to verbal command, speech, or shout. You should give him 3 points. Okay. Whenever the patient comes, he opens his eyes normally. That is a normal phenomenon for. And whenever you call his name, hello, so and so, and then he opens his command, or when you shout at him, then he opens his eyes for 1 second and then closes his eyes. Then it is then it is GCS is 3. And when you try to, if he is not opening his eyes while calling his name, you have to pinch him somewhere, or you have to give him the pain. So eyes open to pain, that is 2. And if the patient is not opening his eyes due to the pain also, then it is a I1. Then it is a I1. Okay, so why I'm talking is GCS questions are pretty high and high and high, and now you have to know the GCS. GCS is kind of like a 5-star rated topic in terms of your surgery. You can expect a question. Okay, so eye opening 4 components. What are they? Spontaneous eye opening 4, and then verbal command. Verbal command
3,
3, and open to pain
2,
and no eye opening
1.
1. And verbal response, the patient is oriented, he's talking fine, he's talking about his family, and he's talking he's not well, then you give him 5. If the patient is having a confused conversation but able to answer the question, for example, like when you ask him any question like how do you do, the patient may say like I'm not good, but he will be so confused, but I don't know what to say. Or either he may have to able to answer you that only 1 point, like no, I'm not good in this thing, then you may give him the 4 points. And if the patient gives you inappropriate response, are the words discernible. Okay, discernible words or inappropriate responses. You ask him how do you do, and he may not talk to you, or he may talk about like something like ooh, ah, or like some other words. I'm not okay, doctor. Okay, the words will scramble. In this scenario, you can give him 3 points. If you say only the sounds, sir, how do you do? Sir, are you good? Only the sound are coming. Only his sound are coming. Then you give him a 2 point. And if there is no sound also, then you give him a 1 point. Okay, then you give him a 1 point. So if the patient is intubated, you should give him a T. You should mention it as T, VT. The patient is intubated and he cannot talk. Okay, clear that? Clear about that?
Yes.
So
Yes, sir.
verbal
Yes, sir.
response cannot be elicited. Verbal response cannot be elicited in the patient who is intubated. Okay, so you have to put in the V column as a T. Okay, so what do you do? Verbal response, if the patient is speaking normally, 5. Confused conversation. Confused conversation.
4,
4. Inappropriate responses.
3,
And incomprehensible sounds of speech.
2,
And no verbal response.
1.
No verbal response. 1. Okay. And motor response, if you ask him to rise up his arm, he rises up his arms, then you may put him on 6. Okay. If you do the painful stimulus, purposeful movement to the painful stimulus, for example, you pinch him and he fold his leg, you pinch his leg and he fold his leg, then you give him a 5 points. And he withdraws from pain, just he withdraws from pain, instead of not moving anything, then you give him a 4. And if there is an abnormal flexion, then you give him a 3. If there is abnormal extension, then you give him 2. And there is no motor response, you give him 1. You give him 1. Clear about the GCS? Clear about the GCS? Clear
Yeah.
about the GCS, people?
Yes,
Okay.
sir.
Now take a note. Take a note. I give you the scenario. You have to give me the GCS. Shall we do that? Shall we do that? Shall I shoot you the question?
Yes.
Okay. A 26-year-old male presented to the ED unresponsive. On examination, patient opens his eyes only to pain and he makes incomprehensible sound, and he shows the decerebrate posture. What is his GCS level? 26-year-old male presents to you in the ED unconscious, and you assess his GCS, and he opens his eyes only to pain, and he makes incomprehensible sounds, and he makes a decerebrate posture. How much do you give? What is his
3 to 5.
GCS? 6.
7.
6.
E2, V and 2.
E2, V2 and M2.
2. Yes.
E2, V2 and M2. It's 6. Okay. Now, a 42-year-old woman presents to ED. You assess his GCS level. She opens her eyes to the verb on call, and she makes inappropriate responses, and she withdraws from pain. What should be her GCS level? A 46-year-old female presents to ED, and you assess her GCS
10,
level.
sir.
She opens
10.
eyes on call, and she makes inappropriate responses, and she withdraws from pain.
E3, V3,
She
M4.
makes inappropriate responses, withdraws from pain, and opens eyes on call. E3, V3, and
M4.
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 E3, V3, and M4. Okay, so you are examining the intubated patient in the ICU and assess his GCS level. He opens his eyes spontaneously and he obeys commands for movement. What is his GCS level? You examining the intubated patient in the ICU, he opens his eyes spontaneously and he obeys commands for movement. What is his GCS level?
10.
10.
10T. Because
V.
you cannot assess the verbal response because he is intubated. 10T. You should mention the T. E4, VT, M6. Okay, what is this GCS level?
10T.
10T. You should mention the T here, people. So what is the maximum score? The maximum score is 15. What is the minimum score? The minimum score is 3 either, or you can say 2T. In an intubated patient, you can say it as a 2T, or you can say in a normal patient it is 3. Okay, so what is the minimum GCS score? 3 or 2T. And what is the maximum GCS score?
15.
15. So you should know the GCS, people, because eye opens to pain, incomprehensible sounds, withdraws from pain. What is the GCS? Eye opens to pain, incomprehensible sound, withdraws from pain. 2 to 4. You should assess within 10 seconds. Because you are in ED, you are in golden hour, you should assess the GCS very fast, people. So you should be very, very familiarizing with this, like a GCS. Okay. Now, again, we try that in a very fast way. Answer in 10 seconds. Okay. I open to verbal command, inappropriate response, abnormal flexion.
9.
I open to verbal command, inappropriate responses, and you may see that there is abnormal flexion.
9.
9, sir.
3, E3,
3.
V3,
V3.
and
M3.
M3. 9. Okay, very good. So I open to pain and confused conversation, abnormal extension. 242. 242.
9.
8. Now in this patient, the GCS is 8. What do you do in this patient? You intubate or you don't intubate?
Intubate.
Brain exam.
Whomsoever is having a GCS of less than 8, you should intubate. Whomsoever is having a GCS of less than 8, you need to intubate because the patient is having a severe brain injury. His gag reflex will not work. His tongue will roll back and it compresses the airway. You need to secure his airway. So clear, people? Clear about the GCS? So you need to do intubation. You need to do intubation. Now, you need to do intubation. Okay, if the patient is presented with the previous, if the patient is presented to you, okay, if the same patient is presented to you with the facial injury where you cannot able to see any mouth or nose, then that scenario you should do the endotracheal intubation. What do you do? What do you do if the patient is presented with a facial injury?
ET.
ET, endotracheal intubation. When you're doing an endotracheal intubation, there are two types you can do. In the adults, you have to do cricothyroidectomy. What do? Cricothyroidectomy. And in the children, you have to do needle cricothyroidectomy. You have to do needle cricothyroidectomy. In the children, you will do the needle cricothyroidectomy. You insert a bore needle and you shoot them, and then you put a, you puncture the thyroid cartilage, and then you connected the tube, you secure his airway. Needle cricothyroidectomy. Okay? Needle cricothyroidectomy you have to do. Okay. Now, speaking about that, what will be the permanent solution? You managed him temporarily, you put a ET, and then you did the cricothyroidectomy, and in the children you did the needle cricothyroidectomy. What will be the permanent solution? Tracheostomy will be the permanent solution. Okay. What will be the permanent solution? What will be the permanent solution? He should be taken into OT, and then he should be performed with tracheostomy. What are the indications for tracheostomy, people? What are the indications for tracheostomy?
Restriction, protection of lower airways.
Protection of lower airways. Okay, indications. And there are two types, elective and emergency. In your situation, you don't need to know elective or emergency tracheostomy. The only thing is emergency tracheostomy you have to know. So you put the incision. Where do you put the incision? Where do you put the incision? Where do you put the incision on the tracheostomy, people?
Second, third, and fourth bracket.
Vertical midline incision from thyroid cartilage. So you measure 2 centimeters below your Adam's apple. Okay, you measure 2 centimeters below your Adam's apple, and then you make a small vertical incision where you can able to identify the thyroid cartilage or over the suprasternal notch, and you can able to make the incision on the second, third, and fourth tracheal rings. Second, third, and fourth tracheal rings, you can do this emergency tracheostomy. So what are the things you have to do in this scenario has been mentioned. So with this, we have covered the primary survey. With this, we have covered the primary survey. Okay, clear about the primary survey, people? Clear about the, sorry, with this, we have covered the airway of the primary survey. Clear about the airway? Why I am talking extensively the trauma is the trauma I am trying to cover all the entire general surgery. Okay, general surgery questions are nowadays more and more when compared to the other things. Okay, that's why, because the systemic area or the portion you study somewhere else, but in the general surgery you will study only that in surgery. That's why I'm insisting and I'm trying to put everything in the trauma itself. For example, we put an organ transplantation in the trauma. Now you go for the breathing. Breathing will be affected by 2 or 3 conditions. What are they? Chest trauma, could be a rib fracture. If multiple ribs are fractured, what could be the condition? Flail chest, pulmonary contusion, any physical damage to your chest area that will compromise the breathing, people. That will compromise the breathing. So that's why I didn't talk much about the breathing. We need to talk more about the circulation. So A was done, B was done, then go for the C. Assess the circulation. So there is a trauma. So when there is a trauma, there is a blood loss. When there is a blood loss, there is a shock. Then there is a shock. So what are the types of shocks you may see in the trauma, people? What are the types of shocks you may see in the trauma? So there are 3 types of shocks in the trauma. What are they? What are the 3 types of shocks in the trauma? Come on. Come on, shoot me over. Hemorrhagic, cardiogenic, and neurogenic shock. Hemorrhagic shock, cardiogenic shock, and neurogenic shock are the 3 types of shock you may see it in the trauma. Speaking about the types of shock and their pattern. So for the hemorrhagic shock or hypovolemic shock, hemorrhagic shock is also called as what?
Hypovolemic.
Hypovolemic shock. That is the shock which occurred due to the loss of blood. So when there is a loss of blood, what happens to the BP? What happens to the BP? Low, because there is a lack of blood volume. When there is a lack of blood volume, the BP will be low. And what happened to the heart rate?
Increases.
Heart rate will be high, and patient will have a cold, pale, and a sweaty skin. and CVP will be low in hypovolemic shock. Very, 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 very important MCQ. That's the difference between your hemorrhagic shock and cardiogenic shock. Okay, CVP will be high in cardiogenic shock, while CVP will be low in hemorrhagic shock. Okay, and the skin changes is the only difference between hemorrhagic or cardiogenic with the neurogenic shock. In neurogenic shock, your skin changes will be the skin will be warm, while cardiogenic or hemorrhagic, the skin will be cold. So low BP, high heart rate, low CVP. What shock hits you on your brain? Low BP, high heart rate, low CVP. What shock hits on your brain?
Hypovolemic.
Low BP, high heart rate, high CVP. What shock hits on your brain?
Cardio.
Cardiogenic. Low BP, low heart rate, and low CVP with the warm extremities.
Neurogenic.
Neurogenic. They ask this type of questions, people. They ask this type of questions. Yes, they give you the scenario, they give you some value of BP, they give you some value of heart rate, and they give you some value of CVP, and they give you whether the peripheries are extremities are cold or warm, and then they ask you to identify what type of shock it is. This type of question will come as a clinical scenario when it comes for the surgery. So the patient with the BP of 60/90 and the heart rate of 114 with the extremities cold and with the low CVP, what could be your answer to that question? BP of 60/90 and a heart rate of 114 with the cold extremities, what will be your question? Answer to this question.
Hemorrhagic.
Hemorrhagic shock or hypovolemic shock? Okay, hemorrhagic shock or hypovolemic shock. If they want to mention you with the cardiogenic shock, they definitely give you the high CVP as a clue. They definitely give you the high CVP as a clue. A neurogenic shock, if they want to mention you a vignette with the hemorrhagic shock, they give you the extremities of warm and pink with the low heart rate. Remember, two parameters, low heart rate and the warm and pink. So clear about the types of shock and their pattern? Clear about the types of shock and their pattern? Yes. And severity of shock, nowadays they are not asking, but remember, only with the urine output you can able to you calculate the severity. So in a compensated and mild shock, you see the normal urine output, decreased urine output in moderate, anuric state in the severe. Okay, and a comatose in severe, drowsy in moderate. Drowsy in moderate. With these two parameters, you can able to easily identify which level of shock the patient in. What are the important two parameters you have to analyze? Urine output and level of consciousness. If the urine output is decreased, then it is a moderate shock. If the urine output is anuric, then it is a severe shock. And the level of consciousness, if it is decreased, then the patient is drowsy, moderate, and severe, the patient will be in coma. The patient will be in coma. You understood the shock, people? You understood the shock? What are the complications? What are the complications and how do you manage this patient? So speaking about the complication, you may end up with the multiple organ failure. You may end up with the multiple organ failure as well as you may end up with the failure of two or more systems. Failure of two or more systems. So what type of organ failures you may see it in the shock? In the case of a heart, you may see the cardiovascular failure. Lungs, you may see the ARDS. Kidney, you may see the AKA or acute renal insufficiency. Or you may see in the blood, you may see the coagulopathy. In the liver, you may see the acute liver insufficiency or acute liver failure. Okay, acute liver failure. So you can see this, the shock complications, it can able to damage your organs. It can able to damage your organs. When it damages your organs, you see the variety of organ defect and variety of organ features. So speaking about the management, or you need to know about one of the important complication. So prior moving on to the important complication, I talk about the management. The management of the shock is very, 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 very simple, people. Okay, what is the management of shock? There are two management. One is a fluid. Shoot him with the IV fluids. Whenever you see the lab values, whenever you see the features of shock, shoot him the patient with the IV fluid, and or if the patient is in a severe shock, shoot him with the vasopressor or inotropic support. For example, what is the drug of choice for cardiogenic shock? What is the drug of choice for cardiogenic shock? Come on, we studied that in the pharmacology. What is the drug of choice for cardiogenic shock? Shoot me the answer, people. What is the drug of choice for cardiogenic shock?
Dopamine or epinephrine?
Mhm. With the oliguria and without oliguria, we have studied two things: with oliguria and without oliguria. Which one is for with oliguria and which one is for without oliguria? Which one is for with oliguria and which one is for without oliguria?
I think
With the oliguria, it is dopamine, and without oliguria, it's norad. Okay. With oliguria, it's dopamine, and without oliguria, it's a norad, not adrenaline. Adrenaline is used for the anaphylactic shock. Okay, adrenaline is a drug of choice for anaphylactic shock, while dopamine is a drug of choice for cardiogenic shock with oliguria. And mostly we give a dopamine only in the ICU setup because the patient has been moved from ED to ICU by the time, and the shock will be compensated or shock will be treated in ICU most of the time. So we will be initiating the fluid. We will be starting them on the inotropes. Mostly we start him in the dopamine. Okay, mostly we start him on the dopamine, either 1 to 2 to 10 microns per kg per minute for that this kind of patient, so that we can able to activate the beta 1 receptor in that patient. So we can able to activate the beta 1 receptor in this patient. Okay, so clear about that? So shock, there are three types of shock. What are the three types of shock, people? Enna type irukku shockla? Faster solunga. What are the three types of shock? You see in trauma. You see in trauma. I should be specific. No, you should see in trauma. Cardiogenic, hemorrhagic, and hemorrhagic, and neurogenic. Okay, which one is having a warm extremities?
Both.
Which one is having
Cardio.
only neurogenic has a warm extremities. Okay, while which one is having a cold extremities?
Hemorrhagic and cardiogenic has the cold and sweaty.
Very good. Which one is having a high CVP? Cardiogenic. Which one is having a low heart rate? Low heart rate.
Neurogenic.
Neurogenic have a low heart rate, and CVP is high in the cardiogenic. CVP is high in the cardiogenic. So these are the things which you need to know. And how do you manage shock? What are the features of shock? Patient will be, like a decreased urine output, drowsy, and you may see that there is a features of shock, and you may see there is a lactic acidosis. Immediately you should start. What do you start on this patient? As a C, circulation. What do you start on this patient? Compensate the blood volume by giving him IV fluids. Compensate the BP. Keep the BP high because the inotropes will keep the BP high. So initiate the inotropes to maintain the bare minimum BP of 90, 60 or 100, 170, and you may initiate the fluid therapy, so increase the blood volume. So automatically in a long-term process, it will be raising the BP and bring back the patients to the from the features of shock to the normal. So reversal of shock can be done in this area. Okay, so next is one of the complication. As I said, the organs will be damaged in the case of your like a shock. The one of the compensation is your severe inflammatory response syndrome, which is a SIRS, where what is the criteria for SIRS? Temperature of more than 38, heart rate of more than 90, RR of 20, TC of more than 12,000 or less than 4,000. Either TC should be more than 12,000 or less than 4,000, and respiration, tachypneic, tachycardiac, and febrile patients can able to get into SIRS. So speaking about the SIRS, if the SIRS is inflammatory response is associated with the infection, then we used to call the test. If inflammatory response is associated with infection, we used to call the test. What do we used to call it? Sepsis. So inflammatory response with the infection, it is sepsis, and a sepsis with organ dysfunction, we used to call the test
Severe sepsis.
Severe sepsis, and a sepsis plus organ dysfunction plus hypotension, then we used to call the test
Septic shock.
Septic shock. Then we used to call that as septic shock. So what is the thing we used to give for the septic shock? Septic shock is an emergency and the SIRS is an emergency. What do? You should manage the ABC, airway, breathing, circulation. You should secure the airway, check for breathing pattern, and do the IV fluids and inotropes to maintain the bare minimum BP and heart rate. Then you should watch for the BP drop, and you should continuously prevent the BP drop by giving a fluid and salt solution. Then we have the SIRS associated with the elevated TC count. So whenever there is an elevated TC count, what do? There should be some hidden infection that could cause an inflammatory response in this patient. So you have to do the antibiotics and then you do the vasopressors for the bare minimum maintenance of your shock. Okay. So apart from that, there is a lethal triad you have to know. What is a lethal triad? What are the components of lethal triad? What are the components? Say it after.
Acidosis, hyperthermia, coagulopathy.
Coagulopathy. I used to remember with the mnemonic of Chinese cha, CHA, cha. Coagulopathy, hypothermia, and acidosis is a lethal triad. If these three combines, and it's a deadly one in terms of a ED. If these three comes in terms of a ED, then it's a deadly one. Okay, you need to be very, very careful because the patient is there. Okay. Then speaking about the cannula size and color, nowadays they are asking. So previously I need to know, so you need to know about the cannula size. So orange color cannula is used for 14 gauge size for the rapid blood transfusion and surgery. So 16 gauge is gray, 18 gauge is green, and 20 gauge is pink. Pink is the most commonly one we use as most infusion and rapid fluid replacement we use as. And 22 gauge is blue. Blue one we uses for the pediatric and neonat. Blue one we uses for the pediatric and neonat. Okay, and apart from if the neonat is too small and you need a bigger needle for the rapid flow, then you can use the yellow one. Okay, then you can use the yellow one. For the pediatric blood transfusion, we can use the yellow one. And purple one, again pediatric. So blue, yellow, purple are all for the baby lovers. And pink, green, and gray, orange are all for the women lovers. That's the adult ones. Okay. So baby lovers, you use as a blue, yellow, and purple, 22, 24, and 26. And for a woman lover, that is the adult one, or men lovers sometimes. Okay. Orange, and gray, green, and pink. Most commonly used one is a pink, which is a 20 gauge needle. Okay. So which one is a pink one? What's the size of pink? What's the size of pink, people? 20 gauge. And what's the size of blue?
22.
Yellow?
24.
And green?
18 gauge.
18 gauge. And purple?
26 gauge.
For pediatric, which one we uses? What are the colors we uses for pediatrics? Blue, yellow, and purple. From 22 to 26 we uses. Which one we uses for the pediatric blood transfusion? That's an important one.
Okay. 22 to 26 gauge.
24 we uses for the pediatric blood transfusion. For blood transfusion specifically. Okay. Pediatric blood transfusion, which one we use is yellow one. Okay, which is 24 gauge. And most commonly used one in the adults is
20,
which is a pink one. Okay, which is a pink one, and very rarely we use as a green one also. Sometimes if the veins are small and you need to get access, so we use as a small needle, 18 gauge needle for those patients. Okay, especially very old people. Okay, so in those patients we use as a 18 gauge needles, which is a green one. When commonly for the adults we put green and pink, and for the children we put a blue, yellow, and purple. Blue will be most common, but for a blood transfusion requirement we put a yellow. Okay, so far done the cannulas and colors, because they may ask you in FMGE. Nowadays these people are out of question and they are taking questions from everywhere. Yes or no? Very bad people. And then you have this injury scoring system, which is not required for you now. So only one injury scoring is very, very important. Abbreviated injury scale, AIS we used to call. It is a 7-digit code which could be represented by 6 pre-decimal and 1 post-decimal one. So the sixth pre-decimal one, if the AAS score is 1, head, 2, face, neck, 3, and 4 is thorax, abdomen is 5, spine is 6, upper extremity is 7, lower is 8, and 9 is unspecified 1. So in terms of critical one, minor, moderate, serious, and unsurvivable. So this is a post-dot, this is a pre-dot. Where are the injuries? You put the number respective to the areas, and then you put a severity over the post-decimal one. So post-decimal one, you put a severity, and a pre-dot code, you put a region of injuries. Okay, that's an abbreviated injury scale. So go for the secondary survey, you ask ample questions. We used to call that as an ample question. What are the ample question in the secondary survey? A for allergy, M for medication, P for PMH, past meal history. Okay, and L for last meal, and E for evidence of incident. Okay, so A, M, P, L, E, ample questions you have to ask. Allergy, medication, past medical history, last meal, and events of incident. Okay, so what are the components of secondary survey? So what are the components of secondary survey, people?
Allergy, medications,
Past medical history,
past
and
medical
last
history, last meal, events of incident.
incident. Okay, those are the ample questions. Okay, what are the primary survey components? What are the primary survey components?
Airway, breathing, circulation, disability, exposure.
Very good, very good. Airway, breathing, circulation, disability, and exposure. So these are the components of your trauma, people. So before I move on to the head and neck trauma, shall I move on to the head and neck trauma, or you need a 5 or 10 minutes of break? Do you need any break? Don't worry that I'm taking trauma for a long time, because I'm including all the topics in trauma itself. So when trauma completed, we will cover entire chota mota topics in the trauma itself. Okay, don't worry about that. You want a break, or shall I move on to head and neck trauma?
Continue.
Can I continue with the head and neck trauma?
Yeah, please
Yes.
continue.
Okay, then we move on to the head and neck trauma. First thing is the base of the skull fracture. What are the signs you may see in the base of the skull fracture, people? Straight picture based question. I don't want to put you more effort on the things, except the few other things in the head and neck trauma we discussed about that. But in the case of head and neck trauma, what are the signs of base of the skull fracture? What is this? This is so called as raccoonize. Raccoonize. I named it. Don't worry, I named it. Raccoonize, which is seen in the base of the skull fracture. And what is this?
Battle sign.
Battle sign. What does the battle sign mean? Sometimes they don't give you the picture. They ask you. They give you the, the meaning or the condition which expressed in the words instead of given in the picture. What is that?
Middle cranial fracture.
Trauma from the person.
What is battle sign? Presence of bruise behind the ear. Bruise or hematoma behind the ear. This is the word they give you that indicates the battle sign. Battle sign is also a sign of base of the skull fracture. Hematoma behind ear. Okay. This is the word they describe the battle sign. Next, what do you see? The base of the skull fracture, you may rupture the nasal bones, and you may also see CSF leak through the skull, and it will leak through the nose. So you may see the CSF rhinorrhea. You may see that there is a CSF rhinorrhea. Okay, then rupture of tympanic membrane. You see the hemotymphanum, blood from the tympanic membrane. Blood from the tympanic membrane, hemotymphanum. So what are the signs of the base of skull fracture? Number one is
Raccoon's eyes.
raccoon's eyes.
Battles.
Battle sign.
Yes, of rhinorrhea.
Then
Hematopharum.
hemotymphanum. Okay, these are the 4 signs that you may see it in the case of your base of the skull fracture. Now going on to the hematoma. So speaking about the hematoma, what are the types of hematoma we are having and what are the main causes? This table is kind of like a 5-star table, people. You should not miss it. So for the epidural hematoma, what would be the most common cause? What could be the most common cause of epidural hematoma?
Middle meningeal artery.
Rupture. So you see in your skull, consider this is your skull, and you see here the pterion. Do you know the pterion? The fusion of 4 bones will occur in the spot of the skull that is so-called the pterion. Yes or no? That's the point, gun point. So whenever the pterion has been ruptured, that's the weakest point of the skull. In the RTA, whenever the pterion has been ruptured, the pterion, that is the structure underlying the pterion, is a middle meningeal artery, branch of a middle meningeal artery. So since this is the weakest area of the skull, this will undergo most common fracture. Fracture of the pterion could result in rupture of middle meningeal artery. When there is a rupture of middle meningeal artery, you may see epidural hematoma. This is a sequence of scenario they may give you in terms of a, like epidural hematoma. So epidural hematoma, pterion fracture, rupture of middle meningeal artery, and then epidural hematoma. Okay. So for a subdural hematoma, what will be the cause? The bridging veins will be torn. The bridging veins would have been torn in the case of subdural hematoma, and you may see the aneurysmal rupture in terms of a subarachnoid hematoma. Okay, in case of subarachnoid hematoma, you may see the aneurysmal rupture. Okay, you may see what? Aneurysmal rupture. And intracerebral hemorrhage, you may see there is a rupture of lenticulostriate arteries. Rupture of lenticulostriate arteries. So aneurysmal rupture, you may see the subarachnoid hemorrhage or torn bridging veins, subdural hematoma, rupture of middle meningeal artery, epidural hematoma, SAH, it's a hemorrhage. Okay, sorry. Typing error might have been had. Okay, epidural, rupture of middle meningeal artery, subdural, torn bridging veins, subarachnoid, it's an aneurysmal rupture. So speaking about the epidural hematoma, what are the things you need to know? Rupture of middle meningeal artery, yes or no? You should see this picture, biconvex shape. It's a biconvex shape or lenticular shape of hematoma. Very, 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 very important MCQ, people. Patient presents with the patient had a fall in the morning. Initially patient had a headache, and then patient was fine for some time, and then the patient now presented with the unconscious. This is so called as lucid interval. So patient presented with a headache, and then later she was fine. Now at present the patient is unconscious, and the patient is having on examination. The CT showed there is a lenticular shaped opacities on the CT brain. Then what do? That is the most commonly EDH. What could be the probable underlying cause? Rupture of middle meningeal artery. Rupture of middle meningeal artery. And most common location in EDH is temporal fossa. Then subdural hematoma, as you said, rupture of bridging veins. So CT showed anga convex na inga enna varum. There you see the convex. So here what you will see? Here what you will see? Concave type of hematoma. Here what you will see? Concave type of hematoma. So in both of the hematoma, what will be the possible complication? We will talk about the whole hematoma back. Okay. Next is a subarachnoid hemorrhage. Most common causes a rupture of aneurysm. We have studied that in the table. Yes or no? Most common causes rupture of berry aneurysm. Very, 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 very important. Trauma, rupture of berry aneurysm. If you do these two, SAH, blindly choose SAH. If you see these two words in the question, clinical based question, trauma, rupture of berry aneurysm, the most common thing you should come into your brain is subarachnoid hemorrhage. So loss of consciousness with a severe headache, worsening headache of the lifetime. That's the key word they may give you. Headache of a lifetime or worsening headache of a lifetime. She never experienced this much type of headache before. These are the keywords they may give you for subarachnoid hemorrhage, and the xanthochromic spinal fluid will be seen. Xanthochromic spinal fluid will be seen. So in all type of hematoma, either it could be a epidural hematoma, or it could be a subdural hematoma, or it could be the subarachnoid hemorrhage. or it could be the subarachnoid hemorrhage, people. There are a lot of things are here. So any of these things, what will happen here is mostly in the case of epidural as well as a subdural hematoma. At present, what will happen? What are the complications that you may see? So you need to know, you already knew what are the things you may see in the epidural, subdural, and subarachnoid hemorrhage. Yes or no? Patient with the lucid interval, what type of hematoma it is? Patient with the lucid interval, what type of hematoma it is? Faster.
Epidural.
Epidural. Patient with the worsening headache of lifetime.
Subarachnoid.
Subarachnoid. Okay, very good. Patient with the concave type of opacities in the CT.
Epidural.
Subdural.
Very good. Subdural hematoma. Convex, biconvex, or lenticular opacities are seen in. Epidural. Epidural. Very good. Epidural. Rupture of perianeurysm.
SH.
Torn of bridging vein. Torn of bridging veins. SDH. Subdural hematoma. Rupture of middle meningeal artery.
EDH.
EDH. Rupture of middle meningeal artery. EDH. Torn bridging vein. SDH. Rupture of your rupture of your perianeurysm, then it is a subarachnoid hemorrhage. Subarachnoid hemorrhage. So in all these things, and intracranial hemorrhage, most common causes hypertension, most common site of intracranial hemorrhage is putamen. So in all types of hematoma or hemorrhage, what will happen is mostly this blood will be present in the brain. Yes or no? Am I right or not? Technically, the blood is oozing in the brain and it is clotting in the brain. Am I right? So what happened to the intracranial pressure?
Increases.
What happened to the intracranial pressure?
Increases.
Increases. When the intracranial pressure increases, you will see the elevated ICP signs like uprolling of the eyes and unconsciousness and all those blah, blah, blah things. And in that scenario, our primary motive is to relieve the pressure from this brain. Okay, so if not, what if you don't relieve the pressure from the brain? What will happen?
Hypertension.
Brain herniation will happen. Patient dies. If you don't relieve the brain, if you don't relieve the intracranial pressure inside the brain, the patient may have the herniation of brain through the foramen magnum, and then it will push out to the spinal cord and patient dies. Okay, this is what happens in terms of this both elevated ICP. So you need to manage this elevated ICP. But there is a problem here. If there is a problem with the function like a hydrocephalus, obstructing hydrocephalus or normal pressure hydrocephalus, you can able to give the osmotic diuretics called as mannitol. We studied in that pharmacology that mannitol creates osmotic gradient and it will decrease the IOP and the ICP. But here the problem is a structural problem because the skull has been fractured, blood has been oozed out, and a hematoma was sitting inside the, what do we call it? Hematoma was sitting inside the brain. Am I right or wrong? Yes or no? If the hematoma is small enough, then we may try something to pull out this hematoma. If the hematoma is large enough and the patient is crashing now, the urgent craniotomy is required. Either you drill a burr hole to create this, to relieve the, like pressure inside the brain, or you will take it up to the craniotomy. You will take it up to the craniotomy and remove the clot manually through the neurosurgery. Okay, urgent craniotomy or burr hole drill is required in terms of this hemorrhage or hematoma. Do you understand now? People, management of epidural hematoma, subdural and subarachnoid hemorrhage. Yes? Clear?
Yes.
Okay. When can you give a anticoagulant in this thing? Because blood clot is there, no? But there is a problem with the anticoagulant. When you give the anticoagulant, what will happen here is the blood has been leaking out and try to form a clot and try to block the further leak of the blood. Now, when you are giving a blood thinners, what will happen? The oozing of the blood will worsen and it will make the situation even more worse. It will make the situation even more worse. So the main choice of epidural or subdural is the surgery, but sometimes if it is in the minimal level, it will settle down. It will settle down on its own. So you need a time and you need some very little amount of the things to pull out that SDH or EDH. The main thing is a surgery. You got it, people? You got it? Now shall we revise the hematomas? Very important topic. That's why I put it in here. Okay, instead of I put it in the other areas or neurosurgery, I put it everything here. So rupture of bridging vein, what type of hematoma? Rupture of bridging vein, what type of hematoma? Faster. Faster, faster.
SDH.
Rupture of SDH. Very good. Lenticular opacities are seen in
SD.
EDH. EDH. Xanthochromic spinal fluid and CSF indicates. Xanthochromic spinal fluid and CSF.
Also epidural.
Subarachnoid. 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 Lucid interval is seen in. Lucid interval. Epidural. Very good. Worsening headache of lifetime. Worsening headache of lifetime. SAH. Very good. SAH. Very good. Concave shaped hematoma, concave shaped opacities in CT.
SDH.
Subdural. Most common location of your intracranial hemorrhage. Most common location of intracranial hemorrhage.
Trigger.
Putamen.
Putamen.
Putamen. It's on the screen. It's on the screen.
Yeah.
Okay. Next area is your diffuse axonal injury. In terms of a brain injury, you may see the white matter damage, that is a DAI. Most common location is your junction of gray and white matter. Most common finding in DAI, very important. Most common finding in DAI is loss of consciousness, and most common post-trauma vegetative state. Patient will not be awake at all, comatose completely. Then it is most common causes DAI due to the axonal injury. Investigation of choice is MRI. This patient won't survive, so automatically the patient dies. Okay, patient won't survive and the patient dies. Okay, next is a Liforti. This is a grade 1 Liforti, which involves only your teeth. Grade 1 Liforti. Grade 2 Liforti, it will involve a part of a maxilla and a zygomatic bones. Teeth along with the upper teeth and maxilla and the zygomatic bones, and then upper teeth, maxilla, zygomatic, nasal bone, and a part of your orbital wall. Then it is a grade 3. Grade 3. This is the classical pictorial representation of grade 1, grade 2, and grade 3 Liforti injury. You can able to identify these things as soon as like you are. So depending upon what type of location they are giving, you can assess the Liforti injury grade 1, 2, 1, 3. Next is a Begwest triad, one of the important MCQ. Rib fracture, spine fracture with the diaphragm rupture. That is a Bergwist triad. Okay, they will ask you as an MCQ point. Bergwist triad, rib fracture, spine fracture, and diaphragm rupture. Okay, then move on to the abdominal trauma. One is the important highlights of the abdominal trauma. Most common injured organ in a penetrating trauma is. Most common injured organ in the penetrating trauma is. What is the most common injured organ in penetrating trauma? Liver over stomach over small intestine. For blunt trauma,
Spleen.
blunt abdominal trauma, spleen. Very important MCQ. The spleen has been asked for more than 5 times. Most common cause of gastric injury.
Penetrating trauma.
Okay, gold standard test for intra-abdominal injuries in stable patient.
CT.
Patient with RPA with abdominal injury, patient is stable, take a CT abdomen. If the patient is unstable,
Ultrasound.
we used to, we used to call that as FAST, focused abdominal sonography test. Okay, focused abdominal sonography test or ultrasound, we used to do it in the unstable patient. And for say a stable patient, we used to do
CT.
CT. So very important. These 4 lines are pretty important lines in terms of trauma. Most common injured organ in a blunt abdominal trauma.
Spleen.
Spleen. Okay, very good. Lucid interval is seen in.
EDH.
Epidural.
Patient eye opens spontaneously. Patient eye opens spontaneously, withdraws to pain, and the patient speaks incoherable words. What is the GCS? Patient opens eyes spontaneously. Patient withdraws to pain, and patient speaks incoherable words. What is his GCS? Faster.
9.
I told you GCS should be calculated within 10 seconds. Eyes open spontaneously. E4.
4 to 3.
Incoherable words, which is a MV3. And withdraws from pain, M4. Withdraws
Yes.
from pain, M4.
2.
Incoherable words, 3. And eyes open spontaneously, 4. So that indicates
9.
the GCSs. GCSs. 4, 3,
GCS.
4. 11. The GCS is 434, which is 11 people. Yes or no?
Yes, sir.
Okay. Biconvex shaped opacities are seen in
EDH.
EDH. Very good. Concave shaped opacities are seen in.
Subdural.
Subdural.
Okay, very good. Most common organ involved in a blunt abdominal trauma.
Spleen.
Okay. If the patient is stable, presented with the abdominal trauma, what could be the investigation of choice?
CT.
If patient is stable, presented with abdominal trauma, what would be the investigation of choice? Go ahead, CT. CT. Unstable patient, abdominal trauma.
Fast.
Ultrasound.
Fast or ultrasound. Focused abdominal sonographic test or ultrasound. Okay. Patient rupture of berry aneurysm is seen in. Rupture of berry aneurysm is seen in.
SDH.
SDH.
SDH. SDH. Okay. SAH, sorry. Rupture of berry aneurysm is seen in. SAH. On-bridging vein is seen in.
Subdural.
Subdural. Rupture of middle meningeal artery is seen in.
Epidural.
EDH.
EDH. Very good, people. Okay. Sure. Now, patient is having an abnormal extensor response. Okay. Patient is having an abnormal extensor response. Patient is having a confused conversation. Patient is open to verbal command. What would be the GCS? 342. We should say it in a very fast way. 342. Abnormal extensor, confused conversation, eyes open to verbal command. E3, V4 and M2. E3, V4 and M2.
Yes.
Sure. So this is all about this revision of trauma, important topics we have covered. Anyway, we'll cover a few more things. Compartment syndrome. So speaking about this compartment syndrome, previously have you studied about the abdominal compartment syndrome? Due to the rupture and blood oozing, the compartments has been compressed and you may see the increased abdominal pressure. You may do the fasciotomy to relieve this compartment syndrome. So long midline laparotomy you have to do. Long midline laparotomy you have to do, and then you have to cover the open wound by facial closure or with the Bogota bag or with the split skin graft or with the VAC closure devices. Okay, so this is a abdominal compartment syndrome management, and for leg compartment syndrome you have to do the fasciotomy. Fasciotomy, what should be the pressure of a fasciotomy for leg compartment syndrome? Very, 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 very important MCQ in terms of your FMGE. What could be the compartment pressure, fasciotomy pressure for a leg compartment syndrome?
30 mmHg.
30 millimeter of mercury. 30 millimeter of mercury should be there. Okay, for the leg compartment syndrome. Fasciotomy with a 30 millimeter of mercury. And for abdominal compartment syndrome, you can grade it with the intra-abdominal pressure. But the maximum grade is grade 4 if there is a more than 36 centimeter of water. Okay, 36 centimeter of the water. Abdominal compartment pressure cannot be measured directly. So you need a Foley's are there. Yes or no? So 3-way Foley catheter, we can measure the intra-bladder pressure and then we can measure the intra-abdominal pressure in an indirect way. Okay. Next is a blast injury. Most common clinical sign in blast injury is very, 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 very important MCQ. Eardrum perforation, people. Eardrum perforation. Most common organ injured in urban bombings is?
Eardrum.
Most common organ injured in urban bombings?
Eardrums.
Most common injured organ injured in immersion blast?
Gastrointestinal trauma.
Bowel. Most common location of bowel injured?
Terminal colon.
Terminal colon and ileum. Terminal colon and ileum. Okay, so these are the blast injury. So most common clinical sign, eardrum perforation. Organ injured is eardrum. For an immersion blast, GAT, and for a bowel, terminal colon. Okay, these are the important things in terms of your trauma. Most common cause of death in earthquake is crush, volcano suffocation, tsunami, it is drowning. Okay, so with this we have completed the trauma, general principle, organ transplantation, and neurosurgery also. Okay, with this we have completed the most of the conditions. Okay, hemotympanum is seen in. Where do you see the hemotympanum? What is the sign of hemotympanum indicates? Raccoon eyes, battle sign, CSF rhinorrhea, and hemotympanum. Yeah, come on, someone is saying the answer.
Is a basal of
base of the skull fracture. Base of the skull fracture. Okay, okay, very good, people, very good. So when do you intubate? Below what GCS score you need an intubation in the unconscious patient?
less than 7.
Less than 8.
Less than 8. Less than 8.
Yeah.
Very good, very good. Okay, what is the management protocol for shock? Hypovolemic shock mainly. What is the management strategy? IV fluids followed by inotropes or vasopressors. Okay, drug of choice for cardiogenic shock with oliguria.
Dopamine.
Dopamine. Very good, people. You have to maintain the BP because in shock there is a low BP and heart rate will be higher. In terms of hypovolemic or hemorrhagic shock, along with the cardiogenic shock, both you may see low BP and high heart rate, cold extremities. What's the difference between cardiogenic and hemorrhagic shock?
CVP.
CVP. Which one will have a higher CVP?
Cardiogenic.
Cardiogenic will have a higher CVP. Which one is having a warm extremities with low heart rate?
Neurogenic.
Neurogenic shock. Neurogenic shock. What are the criteria for SARS?
Sepsis criteria.
More than dash and less than dash. சொல்லுங்கப்பா. More than 12,000 and less than 4,000. More than 12,000 and less than 4,000 in terms of SIRS. SIRS plus infection leads to
Sepsis.
sepsis. SIRS plus infection plus organ dysfunction leads to
Severe sepsis.
severe sepsis. Very good. SIRS, sepsis plus organ dysfunction plus hypotension leads to
Septic shock.
septic shock. Very good, people. What is the size of the pink IV cannula?
20.
20 yellow.
22.
Yellow. 24.
Yellow.
Blue is 22. And what is the size of the green?
I think it's 18.
What is the size of gray?
16.
16.
Orange is 14.
Very good. What's the size of purple?
26, the maximum.
For a leg compartment syndrome, we do the fasciotomy with the pressure off. 26
30
is purple.
mmHg.
For a leg compartment syndrome, we do the fasciotomy. Fasciotomy pressure should be
30 mmHg.
30 mm of mercury. Okay, very good. And we need most common organ involved in the blunt abdominal trauma.
Spleen.
Blunt abdominal trauma, spleen. Very good, spleen. And speaking about that abdominal trauma, patient presents with abdominal trauma, patient is stable. What is the next investigation?
CT.
Okay, unstable.
Fast.
FAST or ultrasonography you have to do. Either USG or FAST you have to do. Okay. So hemodynamically unstable patient, you do the fast thing. And if the fast is not working, what you will do? You will do the emergency laparotomy and explore directly. Okay. If the patient is stable, you do the CACT. Okay. And you should grade the injury. Okay. You should grade the injury. If the grade is 1 and 2, you do the non-operative management. If the grade is 3 and 4, you do the operative management. Okay. You do the operative management. So for a grade 4 or 5 over 3, you do the laparotomy and the splenectomy in abdominal trauma patient. Grade 1 and 2 injury, you will do the just hemoglobin, you will watch for, and any hemodynamic compromise you watch for, and then you take a scan after 72 hours and then check whether the patient is okay or not. Now I'm talking about the, what do we call it, hemodynamically stable patient. Okay, hemodynamically unstable patient, you do this fast and then you do the emergency laparotomy directly to explore where the bleeding is, and you try to control it. You try to you try to explore where the source of bleed is. Okay, and then you have to control it. Okay, clear about that? In the case of abdominal trauma, in terms of especially the splenic trauma, I rather say. Okay, in terms of splenic trauma, I rather say. Clear about that?
Yes.
That will happen in a very tertiary state. Okay, tertiary management. All of them are the tertiary management. Okay, and speaking about that, most common cause of death in earthquake is crush injuries. Most common cause of death in earthquake is crush injuries.